Hi, my name is Dr. Bob Bender. I'm a geriatrician. I have nothing to disclose other than the fact that I am a geriatrician. I'm thrilled to be a part of the Geriatric Lecture Series here at the University of Iowa. Today I'm going to talk about health maintenance of the dementia patient. All of us in primary care are going to see more and more patients with dementia as time goes on. This patient population is exploding in terms of numbers, and fortunately at the same time our insights and ability to both deliver primary care and direct care in regard to the dementing illness is just growing and growing. So we're very excited about this. It's a great opportunity to learn more about serving these patients in this current era. So I'm hopeful to give you some new insights that are delivered practically so you can take this information to the bedside. So we're going to try to present an efficient and effective evaluation. We're going to try to describe the unique characteristics of the more common causes of dementia, and I'm going to describe both pharmacologic and non-pharmacologic intervention options, and we're going to discuss ongoing care, health maintenance for these patients. So the initial evaluation, a complete history and physical. We really want to get to know these patients and all of their various challenges, all their medical problems, and we also want to get to know what sort of psychosocial difficulties they may be facing. Very important to do a really good history and physical. We want to get a basic mental status examination, and really there are many of these available. Usually these are 30 questionnaires that can be done in about 5 minutes, and we get a pretty good idea of what's going on most of the time. It's important to remember that these mini mental status examinations are rough tests. They're not definitive. For example, if you have someone with a really high IQ, a lot of education, they may get a perfect score on this type of an examination but still have significant dementia. And likewise, if someone hasn't had a lot of formal education and perhaps doesn't have a usual high IQ, they may score poorly but have no dementia. So it's important to remember that all of these mini mental status examinations are relatively superficial tests. Then we want to get some lab work. We want to look at anything physiologically that we can find with a hematologic and metabolic profile that might impact the central nervous system. So we want to get a CBC, a basic metabolic profile. I still get an RPR screen for syphilis. We want to get a B12, folic acid, free T4, TSH, liver enzymes, and anything else that the patient's history might suggest. Some people get a magnesium level, some people are getting a homocysteine level, but you want to get a basic metabolic profile that might indicate anything that could impact the central nervous system. And again, if they're on certain medications, you might want to get some blood levels or any other physiologic system test that might be impacted by that particular medication. And then we want to think about getting some central nervous system visualization. The most cost-effective test to get is a CT scan of the brain without contrast. My colleagues in radiology tell me if there is something serious going on, that test will give you a pretty good inkling, and they can advise us as to whether or not further testing is indicated. Now, we don't need to get a central nervous system visualization in many cases. However, it's part of a complete examination, and remember, our culture is so litigious, we want to have a complete workup. One good, hard, and fast reason not to get it is if the patient is in a situation where you know that no matter what the central nervous system scan shows, you're not going to do anything with that information. That would be another reason that would be the major reason not to get a picture of the brain. Sometimes patients just don't want to do that, and their family doesn't want to do it either, so that would be another reason. So, as we evaluate these patients, it's important for us to strive to really understand what is causing the cognitive impairment. There's a mnemonic in geriatrics that is very useful, not only in the evaluation of cognitive impairment, but really I think it's a good mnemonic to have just for a general differential diagnosis tool. So I'll go through this with you. The D stands for drugs. Are there any medications that are potentially affecting the central nervous system? Particularly, are there any medications that were initiated coincidentally with the first appearance of any cognitive impairment. Obviously, any psychotropic medication or sedative, really anything that is known to affect the central nervous system must be suspected. Next, are there any concomitant emotional, psychiatric difficulties? These can mimic the dementing disorders. And then we have the M, stands for the metabolic disorders. We want to get a basic metabolic profile, a calcium, sometimes a magnesium, and look again at the patient's drugs to see if any of those could be affecting that particular set of systems. Then we want to think of endocrine disorders, particularly thyroid, parathyroid, and then obviously the physical examination will give us a sense of whether or not there are any other endocrine disorders like Addison's disease or growth hormone abnormalities or Cushing's disease. Next, we want to think of nutritional disorders like B12 deficiency, obviously malnutrition, folic acid deficiency, and also we remind ourselves under the nutritional heading of the very common difficulty with alcohol. You could also think of that obviously under drugs, but it's so common and sometimes so easily missed, we recommend thinking of it twice in this mnemonic. It's important to remember that as many as 1 out of 10 patients at or over the age of 65 throughout the industrialized world have or have had a problem with alcohol. So having a high index of suspicion is very important. And then also under N, we list the degenerative neurologic diseases. And this is where the money is in trying to get to a solid diagnosis in regards to the overall cognitive decline. As we mentioned that, it's important to note that maybe somewhere around 3% of patients do have a reversible cause of their cognitive impairment, and maybe as many as 20% have comorbidities that if we recognize and improve, we can actually help the cognitive disability. So it's important to have a broad differential diagnosis of why the central nervous system is impaired and look carefully for anything that might be palliated and certainly anything that might be reversed. Then we have the T in this mnemonic, trauma or tumor. If there's any suspicion, this is where our central nervous system visualization can really be very important. And then we have under the I, ischemia, inflammation, and infection. Certainly these sorts of risks come up in the history and physical examination, but again, these things are certainly potential sources of complete reversibility if we can find them. Under the A, we have an arrhythmia, which would be an unlikely cause of a chronic cognitive impairment, but we do need to think about it. And then anemia, and then the autoimmune disorders can certainly impact the central nervous system. Then under S, we have social, sensory, and spiritual isolation. Human beings are meant to be connected, and if for any reason patients are isolated or feel isolated, this can lead to cognitive decline. We also, under the S, include seizure disorders, which would be an unusual cause for any chronic impairment, but certainly for intermittent changes in mental status that can sometimes mimic dementia. We need to think about it. Now, we want to talk about diagnostic accuracy. When I was a medical student, we were taught that the only way to diagnose a dementia was with either a biopsy or an autopsy. Even back then, we weren't bold enough to recommend routine biopsy, so that certainly isn't done. But thanks to the great brain banks around the world where people have donated their brains and their charts, we've been able over the last 35 years to gain information that correlates the clinical history and physical with the neuropathologic findings of the major causes of dementia. So now, with the aforementioned workup and consideration of the dementia's mnemonic, the experienced clinician can make an accurate diagnosis more than 90% of the time just with this particular approach. So we've come a long way in the last 35 years, and obviously the better we diagnose things, the better we can initiate the appropriate interventions. We're going to talk about the most common causes of dementia, and this is really constant throughout the industrialized world. Number 1 is Alzheimer's disease. Number 2 is diffuse Lewy body disease. Then we have frontotemporal dementia. Then we have pure vascular dementia, and then normal pressure hydrocephalus. These 5 diagnoses really make up 95% of the cases of dementia throughout the industrialized world. So we can do an efficient, accurate job for our patients the vast majority of the time. When we approach patients who do have chronic cognitive decline, a dementia, we always should have 5 goals in front of us. Number 1, to make sure that the patient is safe and happy. We want to make sure we do get an accurate diagnosis. Number 3, we want to answer all questions from patients and caregivers to their satisfaction if we can. There's a lot of unusual recommendations out there over the internet and different news magazines, and we want to be patient and answer any questions or concerns or hopes that the patients and their families have. We want to initiate the best treatment. We are now armed with much more insight, and we can attend to these diseases much more effectively. We want to help the patient and caregiver right from the beginning plan for the future in a way that as much as possible we can ensure that the patient will always be safe and happy. These 5 goals should be brought up right from the beginning of our diagnostic process so everybody can be on the same page, and it really is something that can be referred back to by loved ones and the patients as they go through the various stages. So let's talk about these most common causes of dementia. Number 1 is Alzheimer's disease. There are some recent reports that Alzheimer's disease may make up 80% of the causes of dementia throughout the industrialized world. Well, I think that that is probably accurate. I think it's reflected in my own practice where I see up to 60 new patients with cognitive decline every month, and so I think it is far and away the most common cause. I had a young resident with me once and I expressed this particular fact, and he looked at me and said, "Well, that must make your job pretty easy." And I thought for a moment and I said, "I think you've got me, but we still want to make sure that we've done a good workup and that we've looked at all contributing comorbidities so we can do everything we can to protect and perhaps help that central nervous system most definitively." The first sign of Alzheimer's disease is very often a change in mood. So we need to have a high index of suspicion for psychiatric stress, for psychiatric diagnoses, and we also need to be reminded that any time we see a new onset of psychiatric symptoms in the senior patient, we must have a suspicion that there is an early dementing illness, particularly Alzheimer's disease, going on as well. So we want to try to get early diagnosis. Then we have short-term memory. This is impaired early. And then often we have some aphasia, some difficulty in the language area, some apraxia, difficulty doing simple motor tasks. Then we have agnosia, difficulty naming things. Then finally we have impaired executive functioning. Executive functioning is that ability to take in information, assimilate it, formulate a plan, and then carry out an insightful plan. This is actually often impaired early in patients with Alzheimer's disease, and so when we make a diagnosis, even very early, we want to make sure that people are watching over them. Their risk of making poor decisions, getting taken advantage of by unscrupulous salespeople, et cetera, is there from the beginning. So we definitely want to look for this. Our usual mini mental status examinations don't test for this really well, so routinely in my practice we add a clock draw, and that does test executive functioning to some degree. We ask them to draw a circle, put in the numbers in the correct order with good spacing, and then we ask them to put the hands of the clock at a certain time. This is not a bad initial screening for executive functioning dysfunction. Pharmacologic treatment. We have 2 classes of agents. The first is represented by memantine. This is an NMDA receptor antagonist, reversible antagonist. This, in my opinion, is a breakthrough. We want to get every patient, even with early Alzheimer's disease, on this medication, in my opinion. Even though it is not definitive yet, we do feel that this medicine has some neuroprotective help. And also, when we get patients on the Namenda, as well as one of the acetylcholinesterase inhibitors, we feel they can predictably stay in their particular living situation for significantly longer, and we're starting to see good solid data to suggest that patients with Alzheimer's disease on these 2 classes of meds have fewer and less severe neuropsychiatric complications, diminishing the need for other psychotropes as they go through the rest of their life. The second class of agents is the acetylcholinesterase inhibitors. These agents block the breakdown of acetylcholine. We have three that we use: donepezil, which is Aricept, rivastigmine, which is Exelon, and galantamine, which is Razidine. All three medications do have some effect when combined with Namenda, the brand name for memantine. They do seem to benefit patients. This combination slows the progress of the actual clinical presentation of the illness in everyone to some degree. A small percentage of patients have a remarkable improvement for a variable period of time, and we don't want to miss those. So in my work, we recommend patients stay on these medications throughout the course of the illness. This combination seems to prevent high incidence of delirium in end-of-life times, and so again, I recommend that we stay on these. We keep patients on these medications for as long as possible. Side effects are few; they're well tolerated. The memantine can cause some dizziness, some lightheadedness, some constipation, but it's really remarkably well tolerated. The acetylcholinesterase inhibitors are generally associated with GI symptoms. We always start the Namenda first because it seems to block some of the GI side effects that we see with the acetylcholinesterase inhibitors, and so that's our usual modus operandi. Next, we want to talk about diffuse Lewy body disease. This is probably the second most common cause of dementia throughout the industrialized world. It presents in a fairly classic manner. We do see early cognitive decline along with soft Parkinsonian signs. Usually these patients do not present with an early tremor, but they can. What we do see is a mask-like face, a bent-over, simian-type posture, and some shuffling gait, and some postural instability. Also, early on in the course of this illness, one unique feature is that they have visual hallucinations. Often patients realize that they're not real, but they're definitely there, often happening more commonly in situations of low light, and also if patients have some visual impairment. This is probably the only true cause of dementia that has actual reliably testable waxing and waning of cognitive status. They really do have some good days and some bad days. They also classically, early in the course of this illness, have autonomic instability. This is usually represented by constipation and also labile blood pressure. It's important to recognize this. This can lead to syncope. Treatment is available with non-pharmacologic intervention like compression hose, some caffeine, and then also we have medications that can effectively keep the blood pressure elevated. But it needs to be followed carefully because we can go too far in bringing the blood pressure up. Pharmacologic treatment for diffuse Lewy body disease, less well defined than in Alzheimer's disease, but the rivastigmine patch is a breakthrough. This particular intervention, when you have diffuse Lewy body disease or dementia associated with Parkinson's, Parkinson's disease dementia, this can really cover a broad range of symptomatic domains. So we want to start the rivastigmine patch early and be aggressive with it. Usually I start with the patch at 4.6 milligrams. In a month I increase it to the 9.5, and then in another month I go up to the 13.3. This sometimes can make a remarkable difference for these patients. It's not a cure, but it does seem to be a real benefit for many, many patients. We think that what happens is that for some reason the rivastigmine patch selectively elevates the level of acetylcholine in the cortex, where it is markedly diminished in patients with diffuse Lewy body disease. The addition of memantine is somewhat more controversial. I always do add this. It does seem to add to some behavioral control, so I think it's of benefit even in pure diffuse Lewy body disease. And the other reason that I add it universally is that at autopsy, so many of these patients also have the neuropathologic criteria for Alzheimer's disease present. So I go ahead and use this. In diffuse Lewy body disease, it's very important to attend to all of the comorbidities. They often have emotional instability, seborrheic dermatitis, predictable constipation, and the blood pressure instability. So it's important, once this diagnosis is made, to have a thorough survey for these other difficulties that these patients routinely suffer from. Vascular dementia. We used to try to make a major distinction between vascular dementia and Alzheimer's disease. That's not as important as it used to be. We think that only about 3% of the dementias are pure vascular dementias. And of course, these patients present with some functional cognitive impairment that involves memory and 2 or more cognitive domains. They have documented cerebrovascular disease and obviously cerebrovascular risk factors. Their presentation is often associated with an abrupt and stepwise decline coinciding with loss of functional neural tissue. At autopsy, almost always patients with what we feel is a heavy vascular component to their brain disease also meet the neuropathologic criteria for Alzheimer's disease. And this is an important factor when we go to treat these patients. We address the vascular risk factors. We consider appropriate anticoagulation. And then we also consider the memantine and one of the acetylcholinesterase inhibitors because of the very, very frequent overlap. Further, vascular disease, even if it's pure, does put the brain at higher risk for Alzheimer's disease, and particularly the hippocampus for progressive decline. Next, let's talk about frontotemporal dementia. This is actually a heterogeneous group of diseases. As time has gone on, researchers have found that there's more than one type of pathologic deposition that occurs preferentially and relatively heterogeneously throughout the frontal and temporal lobes. We now have 4 subtypes that we can identify. The first is the behavioral subtype. These patients usually present with a personality change. They're often disinhibited, and they have very poor insight into their problems. They are often diagnosed as having a primary psychiatric disorder because they usually do well on the initial screening mini-mental status examination that is done in most primary care offices. So a high index of suspicion for the presentation of psychiatric difficulties in patients that are at or over 50 for the first time should lead us to suspect frontotemporal dementia. The next subtype is primary progressive aphasia. This is where patients present primarily with word-finding difficulties. This also seems to be associated with preferential disease in the frontal temporal areas affecting the speech centers. Then we have semantic dementia. This type of frontotemporal dementia is the type of disease that whittles away at patients' foundation of knowledge, of typical things that are second nature. Then we have the frontotemporal dementia associated with motor neuron disease, Lou Gehrig's disease. This is quite unusual, but it has been identified, and we want to have a high index of suspicion that this may be a concomitant comorbidity with patients with ALS. Insight is growing in regard to basic pathophysiology. Again, it's felt to be a heterogeneous group of diseases, and the nomenclature will certainly change over the coming years. It's important to have a significant index of suspicion, again, when anybody has a personality change, poor insight, and a relatively retained memory early in the course of the disease. Treatment for FTD is really not well defined. Nothing has made a huge difference. Nothing is standard. There is some evidence of using one of the acetylcholinesterase inhibitors, galantamine, in primary progressive aphasia. There's a small amount of anecdotal evidence for memantine being effective in the behavioral subtype. Aggressive management of the psychiatric complications along with family support is really the mainstay of treatment. Finally, normal pressure hydrocephalus, not very common, but this is typified by a gait abnormality, urinary incontinence, and cognitive impairment. These 3 things are very common in patients with the other dementias as well, but it is one reason to go ahead and make sure you visualize the central nervous system looking for ventriculomegaly. The MRI is better. Sometimes if the diagnosis is suspected, but not clarified with central nervous system visualization, we can do a therapeutic lumbar puncture, recording gait before and after the withdrawal of the CSF, and sometimes that can be revealing. The treatment is shunting. At autopsy, a lot of these patients do have concomitant Alzheimer's disease, so it's important to keep an eye on these patients. If they do improve markedly at shunting, it's important to continue to follow them. So, getting into more of the actual health maintenance or primary care for patients with dementia, it's important to remember the basics. This is a list of keys to optimal aging, and sometimes we have an intellectual risk of saying, well, they have dementia, it's just a matter of time, we'll just watch them and keep an eye on them, and we don't attend to encouraging just good, healthy lifestyles, which can enhance the quality of life enormously. These are keys for everyone, including patients, again, with dementia. They can take some work, but certainly encouragement by the physician can be very helpful. So let's go through them. Socialization. As patients go through their dementing illness, they can become very isolated, and this is not good for anyone. So I encourage families to call in friendship chits. In other words, telling good friends that they need to come around and that the loved one might not have the wherewithal to contact them, bringing in family members that can be supportive, and again, enhancing socialization may be the single most important key to optimal aging. Use of talents for self and others. It's important to have, as much as possible, purposeful, enjoyable work for the patient. Rest 1 day a week. This is something that's been quoted in a lot of literature on healthy aging, that people need to make sure that their schedules allow for some good, solid rest. Have a good healthcare team. It's important for patients and their families to have easy access, both for chronic care and acute care. Nothing in excess. Throughout the industrialized world, the most common source of excessive indulging involves alcohol, calories, and tobacco. Attending to those for the demented patient is very important. The avoidance of accidents on the road and in the home. An appropriate safety check of the living environment is important, and certainly looking at the driving experience is very important. Driving is probably the single most dangerous routine thing everybody does. Many patients with early dementia can drive very safely and do very well, but as time goes on, those skills will erode. So having a conversation about driving right from the beginning is very important. Stress management. Looking at those things that are stressful for the patient is very important. From a purely physiologic perspective, stress elevates the level of cortisol in the central nervous system, which directly shrinks the hippocampus, an area involved intimately in memory and new learning. Exercise. Physical exercise may be the fountain of youth, and we're learning more and more about the remarkable cascade of healthy events that occur in the brain with regular exercise. Some aerobics, resistance training, stretching, some skill acquisition are all important aspects of a well-rounded exercise program. Practice brain wellness. We're going to go over those keys here momentarily, but it is important to try to tap into the inherent neuroplasticity that is present even in the demented brain. Certainly it's more effective when applied early, but looking at the potential for the brain to take care of itself as much as possible is very important. And finally, on the keys to optimal aging, we have to optimize one's spiritual life. The data is really incontrovertible that patients who have a healthy spiritual life do generally do better. Brain wellness. We have suspected that these items, these recommendations have been very good for the brain. It's only been recently that the World Alzheimer's Association Basic Science Arm has given the imprimatur of validity to these interventions, but they are important, and we want to encourage patients and their caregivers to practice them. A Mediterranean type diet, higher in antioxidants, fruits, vegetables, less fatty items, more fish, seems to be well documented to be good for the brain. Stress reduction. We want to avoid those situations where patients feel that they're in a situation that they have to attend to but can't, leading to frustration and anger. Sleep hygiene. If people don't sleep, the brain does not function well. There's a tremendous amount of scientific data accumulating to show why this is, but we definitely want to make sure that our patients are sleeping as well as possible. Socialization. Being around people with whom the patient is very comfortable, around people they accept unconditionally and accept them unconditionally is magic. Physical exercise, we've spoken about that. The brain is better perfused. There's a wonderful cascade of neurochemical events that occur with regular exercise. It helps tap into the inherent neuroplasticity that we're trying to enhance. So it's a very important part of overall brain wellness. Cognitive training, striving to learn new things and memorize. This can be accomplished early in the dementing illnesses, and cognitive training should be attempted throughout the illness as much as possible. And finally, meditation. There are some wonderful studies, some of the best by a doctor named Dr. Andrew Newberg, about the wonderful effects of regular meditation on the brain. He's got several books out that I recommend to you. Our research team recommends something called centering prayer. It's interesting to note that Dr. Newberg has studied this particular method of meditation, contemplation in great detail, and the changes that can occur with just 20 minutes in the morning and 20 minutes in the evening in the brain are absolutely thrilling. So we recommend this to our patients. One of the reasons we chose centering prayer is that a lot of patients and their families like to link a meditative method with their religious tradition, and this is absolutely ecumenical, even for those patients that come from a non-theistic discipline, religious tradition like Buddhism or Taoism. They can tap into this very same method using the lexicon appropriate to their tradition. Screening. As we look at health maintenance, what do we say about screening for patients with dementia? We always want to weigh the potential risk versus the benefits. What will be done with the findings? Family and patient preferences are obviously very important. A global statement that we can make with some confidence is that if life expectancy is 10 years or more, we want to consider all the usual screening tests that we do for everybody else. This is an enigmatic area. It takes nuance and attention to the sensitivities of patients and their loved ones, but we don't want to neglect it just because there's a diagnosis of dementia. Patients with Alzheimer's disease are said to be expected to live from 7 to 22 years after diagnosis. So we want to take that into account when we think about screening. Immunizations. Influenza, pneumococcal, the diphtheria, tetanus, and pertussis, and then of course herpes zoster. We always want to consider these for everyone. Another area that I think deserves particular attention in this particular demographic is osteoporosis. We have an epidemic number of cases with catastrophic fractures throughout the senior age group. With appropriate diagnosis, screening, and intervention, we can prevent a very high percentage of fractures. We really can. I have one colleague who suggests that if we get people at the appropriate time with the aggressive interventions that we have available, we can prevent 85% of fractures. So we definitely need to be aggressive about this in primary care, family practice, internal medicine, geriatrics, and really consider screening everybody with a DEXA and a history and physical. So when we think about looking at osteoporosis, we want to get a DEXA scan. We want to score their risk for an osteoporotic fracture using the computerized FRAX tool. You can download this to your computer from multiple app stores. We want to measure calcium, vitamin D, and parathyroid hormone levels. And we want to normalize the calcium, vitamin D, and the parathyroid hormone levels. And then we want to use anti-resorptive therapy, in addition to the calcium and vitamin D, with bisphosphonates or a breakthrough product called Prolia. We also want to consider Forteo, which is an anabolic agent. In my work, I find the Prolia extremely convenient to use. It is cost effective for the patients. It seems to be very safe and more effective certainly than the bisphosphonates, and as effective as the anabolic agent Forteo. It's a shot given once every 6 months, and we have found that it's very acceptable to patients. It doesn't rely on renal clearance. It does not have the potential for GI side effects like the bisphosphonates. Forteo is anabolic, and we often recommend that to our most severe patients, but it's a shot every day for 2 years. Patients don't really like that, and it is very expensive. But we do want to have an aggressive approach to the screening and diagnosis of osteoporosis. When you look at the comorbidities that occur with patients with dementia, often osteoporosis-related fractures are a big part of that. Ongoing care. Give strong consideration to indefinite continuation of memantine and one of the acetylcholinesterase inhibitor for Alzheimer's disease, diffuse Lewy body disease, and vascular dementia. These don't cure the underlying illness, but they do help prevent and palliate the neuropsychiatric complications of dementia. We want to have regularly scheduled office visits, easy access to acute care. As a part of the regular scheduled office visits, we want to make sure that a full problem list is considered every time we see the patient. It's very easy to overlook things like constipation or urinary incontinence. We want to have all their problems available for every office visit and also for any visit to acute care. Palliative care. As time goes on, supportive care becomes more important than aggressive screening and intervention. This is part of the art of medicine. It will be different from patient to patient, depending on patient and loved one's preferences, but it's important to always think about what we're doing to the patient in terms of intervention, in terms of screening. Do the benefits potentially really outweigh the risks? Hospice care, when an individual has 6 months or less to live, this can be an invaluable service. The emphasis on care shifts to supportive care and comfort, addressing all aspects of the patient's situation. This is another place where the complete problem list comes into play. If you know what all the problems are, you can make sure that your care is supportive. It doesn't have to be aggressive. Obviously, we're switching over to more care and comfort, but we can make care and comfort more efficient if we really know what all the problems are. Too many times these are neglected as if, well, we don't need to attend to these difficulties, the patient is dying. We do need to attend to them throughout the course of the patient's life. Additionally, hospice can offer supportive services for the family, and that can be very helpful. Caregiver support. A wise saying in geriatrics is when you make the diagnosis of dementia, the family becomes your patient. Caregiving demands regarding dementia patients can be enormous. Often immediate assistance is needed. Fortunately, there are many resources available in our society, and we need to talk about caregiver issues right from the beginning. We have many support resources available, and really throughout the United States, these things are getting more and more easily accessible. The Alzheimer's Association is an invaluable source of support and information. Aging Resources is a federally funded program. These are throughout the United States. This is, again, federally funded. It's free. They provide an enormous amount of evaluative effort, support, advice, and we consult them all the time along with the Alzheimer's Association. Medicare-funded home health services. In other words, if patients have a nursing need like a wound dressing or catheter change, Medicare will pay for these services and they're invaluable. Then we have privately funded organizations providing supportive services and domiciliary services. These are fee-for-service, but again, they can fill gaps in the ability to meet individual needs, and there are many of them here in Iowa and across the country, and largely they do a tremendous job. Hospital-based social services, calling in social service wherever it's available to try to assess needs and ways to meet those needs on an individualized basis is invaluable. And then we have the county home health nursing, again, another invaluable service that's available rather broadly. It's important for the physician to encourage caregivers to enlist these various agents right from the beginning if they need them, as well as support from family and friends. A shared burden can be amazingly lighter. And it's also important to encourage families to acknowledge that some people can carry a heavier burden than others. It's just a fact of life. So caregivers need to be patient with each other and with themselves. And when they reach their limit, so to speak, they need to be ready to call for help before they go past their limits and get sick or get to a point where they can't take care of their loved one at all. So caregivers should be encouraged to try to follow the same keys to optimal aging and brain wellness. These can be very helpful. And then we want to make sure patients and their families are planning for the future. Discussion of end-of-life issues, financial matters, power of attorney, conservatorship, guardianship, living wills, all very important. A family care conference with patient, family, physician, and social services can be remarkably helpful. Physicians can't know everything. That may come as a shock to some of you viewers, but it's very true. We want to acknowledge all of these needs and call in people with appropriate expertise so that these things can be addressed. That's it. Thank you very much for having me, and I hope some of these thoughts will be helpful, both in your own growth and practical at the bedside. Thank you.